And we would like to begin this morning by actually thanking you all for your time as well as this opportunity. My name is Scott Robinson. This is Danielle Shear, Thomas Leach, and Nathan Pham, and we are your team from Half Moon Consulting. We'd like to begin this morning by discussing what South Tree Health Network is. We will then identify a patient's story and highlight the broader issues South Tree Health Network is facing, followed by a root cause analysis, our action plan and recommendations, implementation costs, and lastly, sustainability, evaluation, and results. So who is South Tree Health Network? We recognize that South Tree Health Network is a clinically integrated network that was formed to take charge of population health with an emphasis in stroke prevention. South Tree Health Network aims for interdisciplinary cohesion, population health, and demonstrated market value. We seek to help STHN achieve these results through use of the Triple Aim. The Triple Aim was developed by the Institute for Healthcare Improvement to optimize health system performance. With the use of this model, we will be able to provide improved inpatient experience, improve population health, and most importantly, improve affordable care.
Our story starts with Lynette Tate, a 53-year-old Caucasian female from Southeast Kentucky. Her journey started at Hazard Appalachian Regional Medical Center, where she was found to have a left hemispheric ischemic stroke. Upon further workup, she was found to have diabetes and hypertension. She was seen by multiple medical staff, where she was eventually transferred to Winston Transitional Care Rehab Center, where she was given additional therapy. She was then diagnosed with pneumonia, which she never had diagnosed before. She had an early discharge to home with Wildcat Home Health Services, where she was unable to use her medical equipment. There are many risk factors for Lynette that led to her stroke, some of which included poor diet and low health literacy. Many shortfalls occurred during Lynette's care, some of which included poor communication between herself and the medical staff that was taking care of her. She did not understand some of her dietary restrictions and what she could and could not eat. There was also a lack of standardizations between the EMR, between the hospital and the rehab center. This led to delayed communications between staff members. There was also a lack of understanding between her own diagnosis and what led to her stroke. Ultimately, she was discharged to home with Wildcat Home Health Services. She was frustrated and she didn't understand why she was brought home so early, and this led to a lot of distrust between herself and the medical team that had taken care of her.
These issues are indicative of larger problems within the community and South Tree Health Network. We began with an analysis of demographic information of southeastern Kentucky as compared to the United States. We used the Behavioral Risk Factor Surveillance System, BRFIS, data, where we found that in Kentucky, there is a higher lack of physical activity, higher number of individuals who are current smokers, a lack of use of the dentist, a higher percentage of diabetes diagnoses, as well as increased obesity rates. These risk factors were shown to increase with age. The number of adults in Kentucky who have been told that they've experienced a stroke is 2.9% higher than the national average. All of these risk factors that were shown to be higher in Kentucky as compared to the US are underlying causes of stroke. We also performed a root cause analysis, in which we identified many major areas that contributed to poor stroke care by South Tree Health Network and in southeastern Kentucky. We identified 4 main areas: prevention, quality, fragmented care, and access. Our recommendations and further information on these 4 areas will be provided through our action plan, in which we focus on the Triple Aim to improve the patient experience, improve population health, and improve affordability of care. We will now go into the action plan and begin with prevention. Prevention is marked in particular by 3 areas: a distrust of the medical system, low health literacy, and very little community support. We felt that it was very important to understand the community that we are working with before we try to implement change. To increase integration with the community, we based a lot of our recommendations off of 2 theoretical models. The social ecological model looks at emphases and influences on health-related behaviors through individual and community, as well as societal influences. At the societal level, we identified a distrust of the medical system. At the community level, we identified a lack of community outreach programs. At the interpersonal level, we identified very little support and high pressure from others. And at the individual level, we identified very low health literacy. Health literacy is defined as an individual's understanding of what contributes to his or her health. As defined by the World Health Organization, health is a combination of physical, mental, and social well-being, and not merely the absence of disease or infirmity. We next look at the health belief model, which looks at the effects on the likelihood of taking action, in particular perceived threat, perceived benefits, and perceived barriers to action. The area in particular that Half Moon Consulting would like to assist South Tree Health Network is through the cues to action, which provide the ultimate trigger to changing health-related behaviors. We have 5 recommendations to address prevention issues that led to poor stroke care. The first of these 5 is a Community Wellness Expo. We would assist South Tree Health Network in creating a Community Wellness Expo, which is a celebration of well-being and health in the community, an example flyer for which is located to the right side of the screen. We would aim to use the Community Wellness Expo to decrease distrust of the medical system, increase South Tree Health Network's integration with the community, and increase health literacy as well. Our second recommendation for prevention is to create farmers markets, in which South Tree Health Network would join together with local producers and farmers to provide access to healthy foods that individuals have difficulty getting that contributes to their increased risk of stroke. This would also assist in our integration with the community and creating community of support at the interpersonal level. Our next recommendation is cooking classes, in which we have done preliminary consulting with business leaders and restaurant managers in southeastern Kentucky who have agreed to work with South Tree Health Network to hold cooking courses for individuals with specific medical conditions such as diabetes, to allow them to see how they could handle and manage their diets at home to increase their health. Our fourth recommendation is smoking cessation courses. We would join together, we would assist South Tree Health Network in joining together with Area Health and Education Councils, AHEC, which does exist in southeastern Kentucky, to send out volunteers and university students to areas that have been identified through community health needs assessments as being in need of these smoking cessation courses. Our fifth and final prevention recommendation is to create a good health marketing campaign. This would also provide that cue to action that triggers the likelihood of changing health behaviors. This would manifest through billboards, radio spots, as well as television ads.
Well, now take a look at quality. Though there are many areas of quality that lead to poor stroke care, we've identified 2 as being most important. This would be standards of care and poor patient outcomes. The reason why we've identified these 2 is without a standards of care, the poor patient outcomes are a result of variability, because where there is variability, it does lead to poor patient outcome. To address this, we would like to use care path involvement, HCAHPS assessment, and physician awareness marketing. Care paths manage quality. What this will allow us to do is set a standard in care and reduce variability. HCAHPS, which is the Health Consumer Assessment of healthcare providers and systems, this provides a clear picture into a patient's experience as well as the quality of care that the actual organization is providing. With reimbursement shifting to quality-based metrics, HCAHPS scores have never been more critical. To focus on increasing our HCAHPS scores, we'll then turn to physician awareness marketing. What physician awareness marketing would consist of is various marketing tools throughout an organization that act as a constant reminder to physicians and employees the importance of communication as well as HCAHPS scores. An example of what you might see would be this poster here. This poster stresses the importance of communication. And what it demonstrates is, if I'm a physician and I'm not cognizant of my tone of voice or my body language, I run the risk of only 7% of the important message I'm sending to my patient actually being understood.
Next, we're going to move into fragmented care and discuss how it's affecting the poor stroke outcomes at STHN. In particular, we're going to look at 2 areas, those being the lack of the care continuum and a non-standardization of the EMR and EHR systems. So what are we going to do about it? Starting at the top left, the first thing that we need to do is have joint staff meetings and outings. STHN is a very robust organization with many providers and many specialties. There is a problem, however, that some of these providers are not contracted directly through STHN, but rather through third-party vendors and contractors. We believe that STHN needs to have joint staff meetings and team-building activities to build the cohesion and increase the continuum of care, ultimately leading to better patient outcomes and a better patient experience. Next, we'd like to have STHN look into hiring case managers. Case managers head the care team for the patient when the patient is unable to do so. These case managers have been proven to decrease the length of stay and increase the profitability that you can see in a patient. These case managers can increase the affordability of care for our patients, allowing us to be a better value for the money that they have to spend. We would also like to see a standardization of the EMR and EHR systems. As mentioned earlier, STHN has a lot of providers. They're not all on the same EMR, even though they all do use an EMR system. This is causing lapses in the care when patients are transferred from one facility to the next, and we would like to address that. This will help increase the patient experience as well as increase the affordability. We would also like to see STHN become a lean organization through the use of Lean Six Sigma. Lean Six Sigma is an ideology used by many other industries that's aimed at decreasing the inefficiencies in a process. Inefficiencies in healthcare can come in many forms, and some of the projects that Lean Six Sigma is used for include staffing projects, eliminating unnecessary costs, as well as patient throughput. This will increase the patient experience, again, as well as increasing the affordability of care by getting rid of unnecessary cost. And finally, medication education. We believe that STHN has to do a better job of managing the medication of the patients, specifically through medication reviews, pharmacotherapy consults, and the overall integration of health and clinical wellness. This is going to increase medical adherence and lead to better outcomes for the patients. And finally, STHN has to be ready to adapt to market changes. And we believe that the best way to do that is by becoming an accountable care organization or an ACO. ACOs have been gaining in popularity, as the graph on the right shows, since their inception during the creation of the Affordable Care Act. Not only that, but also many insurers, including CMS, are moving more towards quality-based reimbursement, and one example of this is the Sustainable Growth Rate, or SGR fix, that is illustrated in the appendix slides that you guys have provided, that we have provided to you. They actually incentivize providers to go on a value-based reimbursement system opposed to traditional fee-for-service. We believe that the action plan we have laid out, that we are going and continuing to lay out, is the first step to becoming an ACO, with the next step being to applying for the Medicare Shared Savings Program.
The fourth factor to poor stroke care is access. Here in Southeast Kentucky, there is a low availability to non-acute services. And even where there are these sites, cost and transportation barriers hinder individuals from getting to them. Our recommendations for access are threefold. One, creating a mobility assistance guide. This is similar to the guide given to people with disabilities. However, this will create a continually updated resource for them to utilize their individual built environment. Two, $4 plan. We have consulted multiple pharmacies in Southeast Kentucky, and they're willing to provide generic medications between $4 and $10 a month for medications used for post-stroke care. And thirdly, insurance signups. We will utilize University of Kentucky students to go out in the community and teach them about what insurance is and what it can do for them. In summary, our triple aim revolves around 4 recommendations: prevention, quality, fragmented care, and access.
We'll now take a look at cost projections. As previously mentioned, EMR/EHR standardization is critical for what we're trying to accomplish. To implement this, it would cost approximately $15,000 to $70,000 per provider, and these costs would vary depending on current systems as well as future organizational requirements. The 5-year benefits at the cost of $70,000, though, are roughly $86,000, and that is with a cost-to-benefit ratio of a 1.23. Again, as previously mentioned, we'd like to hire 6 case managers for, we'd like to hire 6 case managers, and the average salary within the area of Kentucky we're discussing is $67,000. The impact that these case managers actually have on the patients, though, is a decreased length of stay of 2.26 days, reduced readmissions by 5%, and increased revenues through quality improvements. Additional costs we'd incur would be the black belt certification of 10 of your employees. The certification for all 10 employees would actually be $5,000, and then we would request $20,000 for the marketing campaign, which would focus on physician awareness and population health. And lastly, the smoking cessation. This would reimburse students and any other volunteer 40 cents per mile that they travel, which is a standard AHAC rate.
Finally, we're going to move into sustainability, evaluations, and our projected results. Starting with sustainability, the first thing that we need to do is utilize the local university students, both from the University of Kentucky and the surrounding areas. This will allow two things. For the students, we can use them during our health expos, the insurance signups, and other initiatives. This will give them valuable work experience. For STHN, we will gain a pipeline to hiring the best and the brightest of tomorrow, as well as an opportunity to get a labor force at cheaper than market rates. Also, we'd need to talk about the community health initiatives and engaging the community stakeholders. Our initiatives, we believe, can work, but the only way that these initiatives will work is if we can engage the community stakeholders and get the community buy-in that is necessary for these programs to actually be successful in the long run instead of just a one-and-done deal. Next, we're going to move into evaluations. The first thing we need to do is do a survey analysis of different surveys, including the Burfus data and the HCAP scores as discussed earlier. This will give us a benchmark of where we are currently, as well as if the initiatives are working in the long term. Quality metrics, we're going to use quality metrics, specifically quality metrics as laid out by the American Stroke Association, which is also in your appendices if you would like to look at some of the metrics that we have picked out. Finally, focus groups and in-depth interviews will be used with not only the patients, but also with the providers and people that specifically have had stroke care within STHN to see how our initiatives are working and whether these stakeholders are actually going to embrace them. This is the CDC framework for program evaluations. You can think of this as a checklist of things that we need to make sure that STHN is accomplishing when setting up their evaluations. What we would like to put a special emphasis on is making sure that that the lessons that each individual provider and facility is learning is shared throughout all of STHN and not just with their individual system. This will also help with the cohesion of STHN as a whole. So what are our projected results? In the short term, we expect to see an increase in the continuum of care, a better integration of STHN within the larger community of Southeastern Kentucky as a whole, as well as addressing the prioritized community health needs, mainly through stroke prevention and treatment. In the long term, we would like to see STHN become an ACO. We'd also like to see a community behavioral health change with an emphasis on healthy eating, greater emphasis on exercise, and higher health literacy, and finally, increase population health by reducing the incidence of stroke and the prevalence of diabetes. So system reimbursement, how are we going to get paid for this? In the short term, we believe that STHN needs to stay with the current fee-for-service structure and start phasing in quality metrics that insurers are pushing for, especially CMS, and this will start a shift towards capitation. In the long run, we believe that STHN has expressed an interest in getting a greater role in risk contract management. And within 5 years, plan to have over 100,000 covered lives within their facilities. We believe that our initiatives are going to decrease the admissions and the overall utilization of the healthcare services. And under these assumptions, we believe that partial capitation will be the best form of reimbursement for STHN. Under capitation, we're not going to get paid, STHN will not get paid for the number of patients that are in beds, but rather that are covered by their plans. This is a projected timeline of how we see STHN implementing these changes. This timeline is a rough work, and we will work with you to see what your needs are. And that is the end of our presentation. We are Half Moon Consulting. We'll now be taking your questions.
Who'd like to start? Okay. Well, thank you very much for that. A couple of reactions. I very much like the kind of social ecology focus. That was a nice framework to consider in all of this, and I think that's something we can take away and continue to use and think about. So thank you for that. We started in terms of the journey that as it was identified. We really started at the hospital, and obviously, when you made that point, I'm thinking, okay, well, did they even have to get there in the hospital in the first place? So we're talking about admission prevention as compared to, and readmission prevention is in the same mode. So I liked the thought process. I liked the quality analysis in terms of looking at the issues and then tracking what you're doing issue by issue. That helped me understand what you were doing. So thank you for that. Did I understand correctly you were looking to standardize the electronic healthcare record across all of our network's participants?
Yes.
That's
Is that
what
what you're
we'd like
saying?
to do, sir, yes.
Okay.
The standards of EHR, EMR standardization will basically improve all areas of the AAA that we're approaching.
Okay, and it's often the triple aim. If you look at the literature, that talks a lot about not just patient, but almost invariably patient and family. So I didn't hear a lot about how the family. I saw it in the social ecology model, but I didn't hear about family engagement as much as I'd like. So where are you on that?
If I may.
Go ahead.
So we felt that families and individuals in particular who had experienced stroke would be included in those identified community stakeholders who would be involved in the decision of what is most needed within the communities that we're working with. So many of the prevention recommendations are open to families and individuals as well. The Wellness Expo information on cooking classes, that would be opportunities for an individual as well as their family to come in and create that support network. We would also envision that through the focus groups, we would be able to allow individuals who have experienced stroke and their families as well to sort of hear the way that their treatment is occurring, their recommendations for better health, and as well with the increased communication between providers and their patients. That includes the family, whereas in the case that was provided, the family and the individual did not understand the diagnoses and restrictions. The increase on effective communication emphasis would assist the families in understanding the health situation of their loved one.
Thank you.
All right. Well, again, thank you for everything. It was very well done. So just some questions, and I'm going to kind of jump around a little bit, so we'll see how it goes. Community outreach, you did address somewhat how we're going to resource this, but in terms of just boots on the ground, how do you envision us making that happen? I mean, did you give some thought to how many people you need to do it, that type of thing?
Mm-hmm. So we also in the appendix, if you would care, we have cost considerations for a number of these community outreach programs, which I will click to if that's all right.
Yes.
So again, these are a number. The stakeholders that we are identifying, as defined on the slide, are the directors, your board, religious leaders, business owners, farmers, students, etc. The students that we aim to include in these initiatives, the number of boots on the ground, would be University of Kentucky and other university students, a single class year. For example, public health students or health administration students or medical students would provide roughly 80 to 200 students, depending on which university we're pulling from. University of Kentucky would be upwards of 200. And at other universities around the country, it is actually an added requirement of volunteer hours for the students to complete. So it would be that full student cohort moving forward into these communities to provide these interventions.
Okay. Physician engagement, particularly around the awareness marketing piece that you all have. How are we going to get our physicians engaged and get them? What's the value proposition, I guess, for the physicians?
Well, we understand that physicians are really driven by data. So what we would do is we would actually provide the data that proves the outcome of the marketing program and what it'll help accomplish. I think if we show physicians where we're actually lacking in providing the care that we're able to provide, they would be on board with it. And the incentive is a reduction of costs and improved efficiency. This could then the reduction of cost could then end up as money in their pocket potentially, especially with the ACO approach that we take, that you're rewarded with obviously meeting those cost metrics.
Okay, so just if I get this right, so obviously the improved patient experience and the physician being more informed of what's going on And then really the kind of the nugget for the physician is the ACO as we roll that out in terms of the connectivity with the physician. Is that fair?
Yes, sir.
Okay.
And I would also like to add to that, we really push the HCAP scores because HCAPs will be a major determinant of if we are indeed impacting, the area in which we're attempting.
Okay.
And again, showing physicians the increase in HCAP scores, I think that'll show that what they are doing, the marketing program that we have provided for them, it has indeed benefited us.
Okay.
Just
Sure.
really quick, the other thing that we really need to do that we didn't touch specifically on this in the slide is to identify that physician champions, our physician champions within the facilities, and those physicians that we are really going to use to help move this and get the buy-in from other physicians. That's going to be one of the big keys of engaging the physicians as a whole, is to finding those physicians that are really as focused on quality as the board is.
Okay. I do have some concerns around that. I think it's the right idea to standardize the EHR. It's just, how do you, it's just a tough one, right? So
Yes, sir.
I can't remember the specifics. I know we have 2 EHRs, so I'm assuming we'd pick one.
Well,
Was
sir,
that
actually,
your plan?
EMR and EHR. EMR is just an electronic version of your standard
Right.
paper copy of a medical record.
Right.
The EHR is actually more or less the interface that allows your various organizations to communicate to each other. So that would be the main difference between EMR and EHR standardization. And the importance of these two is, with, again, healthcare heading in the direction it is, communication is going to be absolutely critical in order to actually provide the healthcare that we aspire to provide and reduce the costs that are obviously much needed.
So
The system that we would use and the system that we would go with would be based on what the requirements are of the system, but we are under the assumption that there is a system in place that would be the overarching system that most providers are using, specifically through the health system through the University of Kentucky would probably be the one that we went with.
Okay. My last question is around the ACO. Did you all consider other models, and if so, what were they, and then ultimately what convinced you to go the ACO route?
So we did consider other models. We included consideration of what the board had seemed to prefer in the board meeting information that we were provided. And we felt that with the shift towards value-based reimbursements, so specifically through a number of legislative attempts that are currently going on in DC, that the value-based alternative models, patient-centered medical homes, bundled payments, and ACOs in particular, the ACO was the best fit for South Tree Health Network and Southeastern Kentucky.
I have a couple of questions. I like that you identified under quality communication. I'm curious, though, and one of your metrics being the HCAPs, I'm curious about your focus on physicians and how will we bring in the rest of the team? Certainly we promoted team-based care in our network. How will you bring in the rest of the team with a focus on the physicians in your approach? And we have nurses, we have OTs, we have a lot of disciplines working in our hospitals, and all of their work impacts those HCAP scores. Can you expand on that a little bit?
Absolutely, sir. So how we would actually, how we anticipate, getting not only the physicians, but the nursing staff and all other stakeholders involved is, again, just really showing them the impact that their part plays in increasing these HCAP scores and what that actually means to your organization. With getting their involvement, I think that sense of empowerment will not only inspire them to realize that they do play a much larger role than what they may have thought. And I think, again, just that data and showing them really what they're accomplishing, not so much us. I think that will inspire that engagement, and I think that will kind of spread as we continue to show progress.
Pardon me? Okay, thank you.
Okay, well, I think we're into the feedback mode.
Great presentation. You're very, very professional, well delivered. Your slides are fantastic. You clearly spent a lot of time on them.
Thank you.
It was thoughtful. It progressed well. So from that perspective, the nuts and bolts of it were really nicely done. I like that you laid out the fishbone. I like some of the things. I also like the socio-ecological model that you introduced. And actually, I just like that you chose models for both, that you sort of grounded your approach in something. It wasn't just your idea so much as that you said, this is the evidence. Here's our model we're going to use. I thought you put a lot in. There were a lot of moving parts, and I don't think you landed quite the costs and the outcomes. I think there was still a little bit of a gap in what we were going to spend and what we would get. I also think I would be curious to know, or I think it would have been strengthened. Sorry, we're in the feedback mode. I think it would have been strengthened by a little more focus on some of the community partners, and by community partners from that perspective, I mean like public health and some of those structures in our public health system that would have also promoted the prevention piece of this that we need to accomplish. But overall, really great presentation.
Thank you.
Yeah, I would agree. Thank you. It was well done. Really appreciated just the whole layout of the presentation. It was very clear, logical. There was a lot in there, but it was easy for me to kind of connect the dots. So I thought that was very well done. You all seemed to deliver very confidently. You did a really nice job on the Q&A, I think, just handling questions and really playing off one another. So I thought that was quite good. I did enjoy, really appreciated the analysis of Lynette's experience. Really went in depth on that and laid it out step by step. So it was very clear to me, if I'm a lay board member and I heard about Lynette, it'd be very clear to me what happened to her and kind of the gaps, and you did a very nice job of pointing all that out. The RCA I thought was quite good, and I really enjoyed that social ecological model. I thought that was pretty neat as well. So to me, I think very well done, and I think it's what you put forward it's very actionable. I did, in my question on the physician, really getting them engaged. How do we get them to the table? I think what you all brought forward is good and would work, but I do think that's a piece that, from my perspective, is always kind of the missing element in making sure that we've really got the physicians on board and it's, again, the value proposition for them. But I thought you did a nice job of addressing that. And then the ACO, I'm not sure that I'm quite there on the ACO, just given what we're seeing going on across the country right now. But you have to pick a model, and so I don't fault you for that. I just personally don't know that that's the right way to go. So, but well done overall.
Thank you. Thank you.
Okay, everything they said, and and I truly mean that. I think very well done, etc. Kind of interested, and I you brought up Lynette's journey. Well, I mean, where it ended was she's sitting there not being able to afford what's going on, et cetera. So what happens to Lynette? it would have been a kind of a fun, or what would have been different if all your recommendations were in place with what Lynette's experience was? Because I think you did a good job of identifying the defects, et cetera. But what's then the ideal system that we would design? You showed us all the pieces of it, but illustrating it as again, the alternative journey might have been a little bit of fun, and personalize it a little bit too, and from the personalized thing, if you look at the triple aim literature, I mean, I've got a major association with IHI, so I'm all over this. Is patient/family, and you were always referring to patient, and I think in almost everything you talked about the patient, the family was there, was engaged, had to provide support, etc. Agree, they were in that model. But I think that the triple aim literature argues that the patient and the family are literally one and should be looked at in terms of this kind of thing. So I encourage you going forward to be thinking about that sort of thing. I happen to agree with your recommendations financially. I mean, this is a network. We don't have a balance sheet. The balance sheet's just sitting out there in the individual hospital and other entities, et cetera. And so fee for service, start putting the improvement initiatives in place, build out the ACO so you can benefit from those initiatives, but you don't necessarily want to start being at risk until you have some of these implementations in place. And then over time, at the 100,000 member level, it's a very different risk than it is at 4,000 in terms of adverse selection and the kinds of things that can hit you. So I think you hit that. I think you hit that one spot on. Very frankly, I think that was well done. Maybe have a little disagreement on that, but that's okay.
We're going to arm wrestle here in a minute. Rock, paper, scissors.
Right. But after ability is, of course.
Yeah.
And the focus on sustainability, very important. So my point is, it's so easy to, you need to do this, this, and this, but then you had an evaluation mechanism and you had a focus on sustainability, and I think that was good thinking in terms of stimulate, in terms of the presentation. I think, what would have sealed it for me would be if you came back to Lynette and you kind of did that, here's the idealized journey, and this is the kind of situation that other patients will be experienced. Yes, there will be readmissions. Yes, there will be issues. But with our recommendations in place, here's how it looks to individuals and their family. But I think you did a really, really good job. So
Thank you very much.
Thank you very much.
Any? Okay.
Well done.
Okay. Well done.
Thank you very much.